Assalamu alaikum. My name is Mohammad Atif Khan. I'm host and moderator for today's program. Let's formally start the program with the recitation of Holy Quran. A'udhu billahi minash shaitanir rajim. Bismillahir rahmanir rahim. Qul huwallahu ahad, Allahu samad, lam yalid wa lam yulad wa lam yakul lahu kufuwan ahad. Sadaqallahu al-azim. First of all, on behalf of Gets Pharma, I would like to thank all of you for your valuable time to spend on a very important topic, that is recent advances in spine surgery. As we all know that spinal surgery is an intricate process, an intricate decision-making process involving sociological, clinical, and economic factors. To discuss the topic, today we have Dr. Muhammad Arif is here, who's an ex-speaker. Dr. Muhammad Arif is working as HOD, Head of Department, Ortho Department, Atabad Medical Complex, Peshawar. And the panelists, we also have two panelists over here. The panelists of today's session are Dr. Nadeem Razzaq Durrani, who's the Head of Department, Orthopedic Department, Ayub Medical Complex, Aptabad, and Dr. Mian Hanif Sahab, who's working as a Head of Department, Lahore General Hospital, Orthopedic Department, Lahore. Sir, let's not further delay. Welcome to all participants who have joined in, panelists and speaker. I would like to request Dr. Arif to start the session formally. Dr. Arif, over to you, sir.
Thank you very much, Atif, and I'm grateful to Gets Pharma for giving us this opportunity to share and learn from each other. Topic for today's discussion is the recent advances in spine surgery, and as you all know, spine surgery is a relatively newer specialty and it's rapidly evolving. Every day, new advances are coming in, and we are getting advantage from the technology and the new knowledge that are being shared. So I would like to talk about these new advances that are recently introduced into the field of spine surgery, and also would like to share our own experiences regarding these the use of these new technologies. Let's start from the low back pain, and as we all know, this is amongst the top 10 reasons why the patient go to physician, and 80% of the areas they will see treatment or help from a physician regarding acute low back pain at least once in a lifetime. Most of these people, like most of them, would resolve it with conservative measures. About 40% of them would come back with the same complaint within a year, and 80% of them would come back within 10 years. That means it's a recurring problem. It's a very common problem. About 5% of them would persist with this back pain. 95% would resolve with conservative measures. So there are many reasons for the low back pain, and the common reasons are mechanical, which include the disc degeneration, disc herniation, spondylolisthesis, spinal stenosis, infections, which include stomatitis, discitis, tuberculosis, neoplasia, which can be primary or secondary metabolic diseases in the form of osteoporosis and osteomalacia, inflammatory disorders like ankylosing spondylitis and rheumatoid arthritis, psoriasis, etc. And then it can be like a referred pain from the abdomen and retroperitoneal area. So most of these patients would respond to conservative treatment. However, some of them would need surgery. Now, previously we used to do surgery in the like shown in this picture, and we would decompress the spine. We would remove part of the lamina, the ligamentum flavum, part of the facets, and would decompress the spinal cord. This would be the scar that looks like there is considerable dissection with the procedure, and because of that, there is considerable morbidity with this procedure. Now, recently, we have started minimally invasive procedures where we use a small retractor in the form of a tube, and this goes into the target area. It shows us the target area. We use magnification here, and we remove the disc that is seen in this case. So it's a very small procedure. Again, about 2 centimeters of incision, and since there is no periaceal stripping of the muscles, just retraction of the muscle, just splitting up. So therefore, the morbidity has been reduced considerably. Now, let's talk about spondylolisthesis. This is a condition in which one vertebral body slips over the other vertebral body because of defect in the posterior elements. Now, when the vertebral body moves, it causes back pain because of the mechanical instability in that region. And then the referred pain starts in the form of neurological, dermatomal, myotomal distribution, and it gradually increases and may lead to weakness in the lower limbs, claudication in the lower limbs, at times urinary and stool problems. So in the early ages, the treatment was fusion in the form of posterolateral fusion, where just bone graft would be added and a spica would be applied. Now, with the development of implants, now we are using implants. We put screws in the pedicles in the bodies and reduce the vertebral body, bring it back to its original position and fuse it. This gives us much better results, like shown in this picture. So we are doing the same posterior fusion, but using implants. Now, the problem with this is that only posterior fusion may not give you adequate bone surface for fusion. And therefore, it was thought that we should also do anterior fusion with it because most of the vertebral body surface is lying anterior. By removing the disc between the two bodies, we can fuse the two vertebral bodies with each other. So then they started 360-degree fusion using two different approaches, one anterior and one posterior. This is the posterior fusion using the pedicle screws and implants. So by starting the anterior, that's how the incision used to be. We would go through the abdomen, retract all the abdominal contents, reach the spine, remove the disc and put bone graft and cages there and fuse it. And then we will close the wound, we will go back and put implants in the back. And that's how we would complete a 360-degree fusion. It would give considerably better results as compared to only posterior or posterolateral fusion. However, it has considerable morbidity because we are using two different approaches and we are opening the abdomen. This is the picture of Arif where we have gone anteriorly and fused the two vertebral bodies. And this is just to show the anatomy and the vessel that we have to mobilize in order to reach to the spine. Now, recently we have started 360-degree fusion only through the posterior approach, and the approach is called as a transforaminal lumbar interbody fusion, where we put the screws like the way we used to, and then from the side through the transforaminal approach, we enter into the vertebral body and we perform the same procedure which we used to do through the anterior approach. Now we are doing all through the posterior approach with the same results. And that's how it looks after this. But now if you see, we are putting screws here, 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 and we are putting a cage here. So again, this has to be a longer incision, and again, it has considerable morbidity. So now, later, during the last few years, minimally invasive spine surgery has been started, where we have considerably reduced the amount of dissection that we used to do previously. Now, with these small retractors, tubular retractors, we pass them, they reach the target area, and we perform whatever we want to do through these small tubular retractors. So that's how it goes. This is the target area. And here we remove the disc, and we also put the screws, and we also put the cage and the bone graft all through just this small retractor. And without damaging the muscles. This is just muscle splitting, it's not elevation of the muscle. So it reduced the morbidity considerably. Now, this was the wound complication previously with the open technique. And now you can see this is a very small wound with minimum complications. This is another TLF L5S1. Now, let's talk about the pedicle screw fixation. In order to perform stabilization procedures in the spine, In deformities, in many instability areas, we pass these pedicle screws and then correct them with the rod. In case of deformities, we start from top of the spine, go to the bottom of the spine, open the whole spine, and do this procedure. Now, this is a very good procedure, but there is considerable dissection because we have to open the whole spine. Now, with the development of MIS system, we are now putting all these screws through the percutaneous route. Without opening it, just with a small stab wound, we go into the pedicle. You can see this pedicle. All this procedure is done under image intensifier. You can see the pedicle. Through this pedicle, we enter into the vertebral body and pass the screws. I will just show you a few pictures. That's how we do the pedicle. The needle goes in. We make a hole into this pedicle, go into the vertebral body. That's how it is done. And see this is the marker that has gone into the vertebral body. And this is the screw which is going through these small stab wounds. And through these extensions, we put the rod and connect these screws with each other. So now you can see this was the previous approach, the long scar involving the whole of the spine. And this is the scar with MIS system, very minimal. The patient become mobilized immediately the next day with considerably less morbidity as compared to the previous procedures. Now let's talk about the anterior approach to the spine. Now there are a lot of diseases which needs that the spine should be approached through the front. And again, as we discussed earlier, so we have to go through the abdomen, retract all the contents, mobilize all the vascular structures, and only then we can reach the spine. And we do whatever we want to do. Now we have started minimally invasive direct lateral interbody fusion, where we move from the side and through, with the help of tubular retractors and image intensifier system, with a small incision, we reach to the target area and perform the same procedure for which we needed the open dissection. So that's how this tubular retractor works. They go right over the top of the target area, and now we reach the disc. We remove all this disc through this tube, and that's how this is done practically. So this is the tubular retractor, and this is after removal of the disc, the cages have been placed. This is called a minimally invasive delift procedure, and we achieve the same result which we usually we previously would achieve through laparotomy. Now this is the wound that previously we would produce in order to reach to the spine, and now this is the incision or the wound now that we are giving, and we achieve everything through this small wound. Now again, we go to the back and then put pedicle screws. Previously we used to do it through the open method. Now we are using percutaneous methods, and these small stabs are these incisions through which we pass the screws. And that's how it looks in the x-rays. So there are two different procedures, all performed through minimal invasive means and with considerably less morbidity. Now another area which is considered as a very difficult area is the upper cervical spine. And Odentite fracture is one fracture which is very common and is caused by motor vehicle accident, falls, diving injuries, other mechanism. Now there are three types of it. Type 2, which is fracture of the Odentite at the junction with the body, is notorious for developing non-unions, and this may cause considerable morbidity and neurological problems if this is not properly treated. So previously these all would be treated conservatively. Now we are stabilizing them. This is an open mouth view where you can see a fracture at the junction of the Odentite with the body, which is type 2 fracture. And we do this all with image intensifier through the neck. We pass this wire into the Odentite process. We drill over it. We pass the screw. We achieve compression, and the Odentite is stabilized. Now let's talk about deformities. Deformities form a considerable portion of spine practice, and these are considered as difficult problems. In the West, they have controlled, they have such a good health system where the deformity would not progress to a very advanced stage. However, we don't have these luxuries, and we usually see the patient when the deformity has progressed to a very advanced stage. So you can see this is a small deformity, but this is not a very advanced curve, and it has been corrected beautifully. But we don't see these patients, we see patient in a very advanced stage. Now, this is one patient with spondylitis. If you can see, he has considerable sagittal deformity. He has got hip flexion contractures. He has got knee contractures, and he walks with great difficulty. He cannot lift his head up, and his walking distance has been considerably reduced. Now, this is a curve of 93-degree, and it's not only the spine, it's also the hips that is producing the deformity. Now, we operated on this patient, and you can see it was not possible that we could place this patient flat on the table. So we have to put a lot of pillows beneath the abdomen of this patient in order to give it support. And we osteotomized the spine, and we stabilized with pedicle screws, and that's how it looked after correction of the deformity. You can see this is the area where osteotomy was done, and these are the screws, and this is the rod. And this is just to show that there's nothing lying in front of the spinal cord. All the bone has been removed, and that's how we are able to correct this deformity. And this is the postoperative picture. You can see the osteotomy that was done here. And this is the patient who is now walking. He is now considerably better, if you can see his previous picture. And when he came during the first follow-up, he was so happy, and he said he was able to see the sky while standing 18 years for the first time after 18 years. So this is the advantage of this procedure. This is another patient, again in Kyphosic spondylitis, and he used to walk with 4 limbs. You can see there is considerable deformity, considerable hip flexion contractures, knee contractures, and he had ankylosed hips. And we first did osteoclasis of the neck of femur. We did traction. We did total hip arthroplasty on one side. Unfortunately, the other side got infected, so we fused it. And after this, we did osteotomy for the spine. We osteotomized it at 2 different levels, and then corrected the spine and stabilized it. So you can see the patient, it was not possible for him to lie flat. So we have to improvise this procedure, positional arrangements. This is how he was on the table. And this is after surgery, the spine has been corrected, and this is the position after the surgery. And now he is walking straight, and he is doing his daily routine activities. Now, there are a lot of congenital deformities that present to us. And again, unlike the West, they present to us when it is too late, and they have already developed neurological symptoms. This is one of our patients who was 15 years old, and he had congenital kyphosis, multiple hemivertebral bodies, and he presented with neurological signs. And this is our operative procedure picture, and you can see the whole spine has been removed in front of the spinal cord. There's nothing in the front. We broke the spine and then corrected it and then stabilized it. And that's how it looked. And all this was done through the posterior approach. Therefore, the morbidities can be reduced to only one approach while considering as compared to 2 approaches. Now coming to the tumor surgery, and now we are routinely doing this kyphoplasty procedure in case of tumors, in case of mats. In those tumors where we can completely remove the tumor, we are doing in-block resections where we remove the whole of the vertebral body completely without leaving any remnants, and then replacing it with the titanium cages filled with bone grafting. and so we can remove the primary tumor from these locations. This is how it looks. This whole vertebral body, both anteriorly and posteriorly, have been removed in one block, and then this is stabilized. The cages have been placed, and that's how it looks in the post-op picture. And this is just to show you the neuromonitoring. This is a device which guides us during surgery if there's any damage to the spinal cord or if any danger to the spinal cord. So it tells us right at that point. And so the chances of spinal cord injury can be minimized because all these procedures are very riskier procedures, and there's a considerable chance of damage to the spinal cord. So previously we used to do without neuromonitoring, and we would come to know about the neural damage only when the patient has recovered from the anesthesia, but then it would be too late. Now with the use of these neuromonitoring device, we are able to identify a neural damage right at that point and immediately rectify it, so this can considerably reduce. And that's how we are able to do all these severe deformities. Now, lastly, I would talk about endoscopic spine surgery. This is the latest that we have started doing. And this is with just a small cannula. We can do considerable procedure, quite a few procedures. We can do disc excision. We can do spinal stenosis. We can even do procedures in the cervical spine and thoracic spine. So this is the arrangement. We have image intensifier, and this is the monitor of the endoscope. And this is a small cannula that goes in, and we see everything on this monitor. And we can remove all the disc that is there. We can decompress the spine with considerable morbidity, and this is the scope that goes in. We confirm the position of the scope with the image intensifier that we are in the right place, and then we start the procedure. This is a short video of how we do endoscopic discectomy. So these are the muscles, and we coagulate them with the RF ablator. So you can see all this, the red is the muscle and the white is the ligamentum flavum. And now we remove the ligamentum flavum with a scissor. We give small cuts into it, and these are the bits and pieces that we are removing. Now this is a hole made in the ligamentum flavum. Inside this, you can see the dura, which is pulsating inside. And now we are extending our hole, and we are going toward the lateral side. So now gradually we open that area. And this is a considerable magnification. This is a very small hole, but since this is magnified, that's how it looks like that. Now we are retracting the neural structures, and beneath that we can see the disc. So once we retract the neural structure, we rotate the cannula, and that will retract all the structures. And now the dura has been retracted, and this is what the disc is lying, very safe. All the new, this is the neural structure that you can see now. And now we are removing the disc. So in bits and pieces, the whole of the disc is removed. They are the disc pieces that we are removing now. So this white is all the disc, and this how this is removed. And this is the hole that through which the whole system has gone and removed the disc. So and this is the pieces of the disc that you can see. So now you can imagine that the morbidity in this approach would be considerably less, and this is usually done as a day procedure. This is one of our patients in the evening of the surgery, and you cannot even imagine that he has gone through a major surgical procedure in the morning. This was our team when we started the endoscopic surgery 2 years ago. And this is the core team of Hyderabad Medical Complex. This is Dr. Sattar, who is an assistant professor in spine surgery. And this is Dr. Zahid, who is an assistant professor in spine surgery. So this was our experience with the recent advances in spine surgery. And thank you very much. Now, if there are any questions, comments, I would like to reply to you. Thank you very much now.
Thank you very much, Dr. Arif Khan. That was really informative, and your experience regarding spinal surgery. Definitely, we cannot cover it in 1 hour. so it needs much time. We have also a panelist with us. First of all, I would request Dr. Nadeem Razzaq, who belongs to Ayub Medical Complex, Head of Department. Sir, would you comment on the spinal surgery, the recent advances as shared by Dr. Arif?
First of all, I will congratulate Professor Arif for presenting such a fine lecture on the recent advances in the spine surgery. I think he has covered almost all topics, but he is practicing in his public and private places, including MISs, including endoscopic surgery, which is the latest of fashion in vogue in the world for a lot of problems. It was a beautiful presentation, and for some people, and I believe that people will be gradually moving toward these small procedures done through small hole with minimal morbidities and excellent outcome for the patients. Other than that, I think the pioneer surgeon in the spine surgery is made a great effort and great contribution to start even the endoscopic stuff in the spine, which is a great revolutionary thing. I'll now request Dr. Hanif to give his experience about it. I've seen a lot of things like, disc fusion, minimally invasive procedures, other things, tumors, vertebroplasty, kyphoplasty stuff. Even in osteomyelitis, they were just putting in 2 cannulas and aspirating liters and liters of pus from tubercular spine. But these are good weapons to be used in spine. Whenever there are facilities and trained personnel available to do the wonderful thing it is. And I appreciate the effort of Arif Khan again. Thank you.
Thank you, Nadeem. Thank you for the comment.
Thank you very much, sir. Thank you very much. Now I would request Professor Hanif, Head of Department, Orthopedic Ward, Lahore General Hospital, to say a few words on this topic.
Thank you very much, Professor Arif Khan and the guest farmer, for your invitation in this very valuable forum. I do remember the words of one professor from Hong Kong. He came in Pakistan, and someone said, we are doing a lot of minimally invasive spine surgery since 2003, and we have got a lot of problems. He said, I'm not in favor of doing minimally invasive surgery, but I'm in favor of doing a minimally invasive to spine. I mean, you must be very precise. Your diagnosis must be very clear and precise, and you have to do whatever you want to do. That should be precise, and the patient is not coming back with other problems. So what we see in our clinical setup is this back pain is very challenging, and the patients, almost more than 50% of the patient in our OPD are of low back pain. Multiple patients have got previous surgeries. Now, after a few years, they got another problem. So they have either the wrong diagnosis, or the diagnosis was not correct, or there was some issue in the management. So again, I'm going to the basic issues of the back pain. That's we have to differentiate the axial pain from the extremity pain. And I have seen few cases with, the pain from the hip and the pain from the shoulder. They can mimic the symptoms of the low back pain and the cervical pain. And one patient I do remember, he came to me after one surgery of for the disc prolapse. He was diagnosed having radiculopathy, got MRI and treated, and discectomy was done at L4-5 level. So after a few days, he got again the recurrence of the symptoms. They went again for MRI. Again, patient was advised for another surgery because previous surgery was at wrong level. Now they are going to operate upon the other level. Luckily, the patient came to me and I diagnosed the patient having avian of the head of the femur. So basically, the patient was having this issue, and that was, having close resemblance with the low back pain and the radiculopathy, and the same procedure was done. So we must be very careful in diagnosing low back pain, the other conditions that mimic these issues. So we must be very precise in diagnosis regarding issues if the problem is from the anterior column, from the middle column, or from the posterior column. So we must be very clear, either this is a facet pain or this is a pain from radial annular fissure or from the disc prolapse, which is causing neurological symptoms. So we all know the red flags, and we must know the trauma, tumor, infection, acute cardiac syndrome, the other conditions. But the yellow flags, we must know that the patient comes to us with biopsychosocial issues and psychosomatic symptoms. And these psychosomatic symptoms present with physical ailment, and the physical ailment can present with the psychosocial issues. So if we treat that physical ailment and the patient's psychosocial issues are resolved, and if we don't resolve the psychosocial issues like job loss, satisfaction, and the occupational stress, and the patient will present to us with these problems in future, and the recurrent issues of back pain, the other issues the patient coming with us. So I'm in favor, we have to come up with a complete, with a perfect diagnosis and correct diagnosis, keeping in view the history, the physical examination, imaging studies, including radiographs, MRI, and the CT scan and the SPECT scan. I do remember a few patients after discectomy came to me back again with the symptoms of the foraminal stenosis, and we went for CT scan, and the CT scan was showing some osteophyte and the foraminal stenosis because of bony spur, and that was causing stenosis of the foramen. So we must be very careful. If we think the patient is of middle age group or the old age group, we must have CT scan along with MRI, or if the patient having chronic disc disease, so we must know there must be some osteophyte along with that can compress the foramen, and we have to treat accordingly. So the diagnosis I'm stressing upon, the diagnosis is very important. And in selected cases, we can go for provocational and interventional diagnostic procedures. Like if we are suspecting this is after history, physical examination, and investigations, and even SPECT scan is very important. That's very sensitive for edema and inflammation of the tissues. So we have to go for interventional diagnostic studies like medial branch block of the dorsal ramus. We can put a xylocaine injection or the lidocaine injection into the facet joint so that we are precise that this facet is painful, and then afterwards we can judge it, and we can treat it accordingly, either with the steroid injection, either with the radiofrequency ablation or neurotomy of the nerves, or we can go for arthrodesis of the specific area if needed. So I will add a little bit in it that in chronic disc we see that there is some issue with the disc, and we are going for just a discectomy. The other discectomy we had to add fear. Now recently what we are doing in our setup is we are doing percutaneous lumbar laser disc decompression. We are using a laser probe in certain cases of disc prolapse, and not in and in disc protrusion, not in disc sequestration. But in certain selective cases, we are going for this lumbar laser discectomy, and we have got a very good result in those patients. And we are doing this procedure routinely in our setup under local anesthesia. Patient is coming in the theater. We are doing this procedure, and after the surgery, the patient is going away without any issue. So these are the recent advances, and Dr. Arif Khan has shown the osteotomies of the supine. Previously, we were not doing. Now, recently, we are doing all these osteotomies, B-lift, D-lift, the other procedures, and they're very good for the community, and with a very less morbidity and the mortality. And we are all with the hope that we are developing this specialty in Pakistan, and we are going a lot of research work and the studies here, and we are going to present our research papers and the articles at international forum along with Arif Khan and the spine team here. Thank you very much, everyone, for listening.
Thank you very much, and Dr. Professor Hanif Saab, who is head of department, Lahore General Hospital. Thank you very much, sir, for your valuable inputs. And definitely it will give a guideline to all those doctors who are participating in this session. Thank you very much. Sir, we have some questions. What happened during procedure if you discover another spine problem aside from one being treated for?
Okay, so just like Hanif said, the most important part is to have a good diagnosis. So we should use all modalities in order to reach to the correct diagnosis, and we should not have surprises during the surgery. Having said that, sometimes it does happen that in spite of doing a lot of investigations and doing all the modalities, still we see something which was not there. So then we decide at that moment, if we can remove that problem, if we can alleviate that problem, we will do that. If that is not possible, we would just record it and do with the original procedure. And then later on, would make another plan for treatment of that other pathology.
Okay, thank you, sir. Another question, after procedure, will patient have to wear back brace or use another medical equipment?
Well, it depends what procedure we have been doing. If you are doing discectomy, we don't need any brace with it. If you are doing endoscopy, we don't need any brace with it. If you are doing MIS surgery, we don't need any brace with it. If we feel that the patient bones are so weak that the implants that we have put in, they may not be very strong. So only then we would like to give additional support. Otherwise, routinely, we do not aid additional supports. Our implants, our fixation is usually good enough to provide enough internal support that it can take the weight of the patient.
Okay, thank you, sir. Thank you very much. Another question we have, what type of activities a patient need to avoid, and how long should he or she limit physical activities after the procedure?
So well, it depends which procedure have we done. If we have done a minimal invasive procedure, if we have done an endoscopic procedure, there's no limitation. The patient can start the routine activity the next day. Having said that, we should always remember that if somebody has got one bad disc, he can always develop another bad disc. So if there is something wrong in his occupation or is in daily habits, he should try to work on that so that his other disc also does not wear and develop problems. We should work on the muscles to develop the muscles, because usually these patients having pain, they do not use their muscles for a considerable time before surgery. And when we operate on them, their muscles are already atrophic. So these patients have to work on their muscles because they provide the main stability to the spine. So they have to work on them, they have to develop on those muscles, they have to do exercises for the muscles. And once the muscles are strong again, then they can be totally normal.
Okay, thank you, sir. Thank you very much for those answers. Thank you to all our speaker, Dr. Arif Khan Saab, Dr. Nadeem Razzaq Durrani Saab, and Dr. Professor Hanif Saab for your participation and for your expert opinion. On behalf of Gets Pharma, I thank you all the participants and the panelists and the speaker. I must say that this was a very comprehensive discussion and a very informative one. I would like to close the session, hoping to have a healthy outcomes in the future.
Thank you very much,
Thank
all
you
of you. Thank you, Hanif. Thank you, Nadeem, and thank you, Gets Pharma, for giving us this opportunity. And have a good day. Thank you very much.
Thanks, Gets Pharma, for arranging this short meeting, which was very informative. Thank you very much.
Thank you very much, sir.